So to lead us off, we have Anik. And I'm going to turn it over to Dr. Anik Borquez to talk about her study.
Thank you, Jill. So I'm going to be talking about the ENCORE study today. It's a study for transgender women across the United States. It's a cohort study of 2 years that has two key aims. One is investigate the impact and acceptance and feasibility of digital/hybrid cohorts. So basically, this is a cohort where all participants will be recruited and will do all their participation online. But there are 6 cities in the United States where we're also recruiting people in presence and helping people fill in their surveys and do their HIV test on site. And so basically it's comparing participants that were recruited through the online means versus those who were recruited in presence. And the other key goal of this study is to ascertain structural determinants of HIV prevention and acquisition. So basically this is a study for transgender women who are HIV negative, as it aims to measure HIV incidence and its determinants. We can move to the next slide. So in terms of where, when, and how much, as I said, it's national. This is a follow-up of an existing cohort which ended about a year ago called LIGHT, that only focused on the east and south of the United States. So here they're expanding to the entire country. Most of the sites were already sites during LIGHT, but a couple have been added, including us in San Diego, and we're the only site in the west of the United States, as you can see. So we're hoping to enroll as many participants as possible so that we have a representative sample for our county, and we can say more about the situation of transgender women here in San Diego. And so compensation is $80 per visit. There's 5 visits over the 24 months of follow-up. And so these are biannual visits, $15 for filling in the survey and $65 for sending back the HIV testing kit. Because for most participants, this is online. They get a testing kit at home that they need to send back with a prepaid envelope. This is not a home test. It's just a sampling kit, either with a dry blood spot or with saliva. And this is just showing you the timeline of when we started enrollment in spring of 2023. There's going to be 3 rounds of enrollment, spring of 2023, then fall of 2023. And now we've just started on March 1st, the enrollment round for 2024, and it should be the last one. The goal is to recruit 3,000 participants across the United States. We're at this stage slightly over 1,000. So there's a big push for recruiting everybody in this next, oops, you've slipped the slides again, Jill, but that's all right. So yes, basically we will be enrolling people up to June 2024. And any help sharing that information is very welcome. In the next slide, I've put some flyers. And we're still in presentation.
Can you see it now? No, I'm so sorry. I tried to do something stealthily. I'm having major computer issues. Let me, did that do it?
Yeah, that does it. That does
okay.
It.
Yeah, sorry.
So these are the flyers that we're hoping, oops, just, these are the flyers that we're hoping you can share with any of your patients or clients in Spanish and in English. And I'm also sharing, I mean, I'm totally aware you're not going to have time to read this, but this is a newsletter, the first newsletter for the study that presents some preliminary results from the previous 2 rounds of enrollment. And it just gives you an idea of what issues can be addressed with these data. And on this newsletter, we focused on transmigration and safety, and whether people felt safe in their state and whether they felt like migrating to another place just to feel safer. And the numbers are quite striking. So just a big thank you to all colleagues and collaborators involved. I should have said this is a study led by Johns Hopkins, by Andrea Wirtz at Johns Hopkins, and by Sari Reisner, who was at Harvard and moved to Wisconsin or another cold state that starts with a W, I can't remember. Also, a big thank you to our current and future participants for sharing their experiences, and thank you for your time this morning. and for Jill, too, for moving around the slides and keeping it going.
Anit, just a quick question. I love this idea of the newsletter. Whose idea was that? And is that something that's going to be monthly or quarterly or anything like that? Can you tell us about that?
Yeah, that's something that actually they were already doing with the light cohort. And this study, some of the co-investigators, there's 3 transgender women organizations who are co-investigators in the study. Ariana Grande, I always forget the name, but Trans Black Coalition, something like that, and Trans Solutions. And so I assume that they were involved in like developing the newsletter during Light. And it's quarterly. We've thought about doing it monthly, but they were like, no, it's impossible because you have to analyze the data and it's just too much. But yes, it's going to be happening quarterly, and this is sent to all participants. So the idea is that participants staying kind of informed of what their data is doing and how it's helping potentially change policy. And it's also because it's a cohort that's online. And so it's a way of trying to keep people engaged, because it's easier to lose them to follow up when there's been absolutely no contact with staff or anyone.
Okay, thank you so much.
Thank you, Jill.
All right, we're going to move on to our next presenter. We have Dr. Danielle Campbell. Sorry, y'all, I'm really having some issues. There we go. Just toggle me when you need me, Danielle.
Thank you. It's doctoral candidate.
Oh, what? Yeah. Oh, doctoral candidate. I'm so sorry. Doctoral candidate, Danielle.
Thank you, Jill. And much like Anik said, I appreciate the opportunity to come and share about a few studies that are coming out of the iStrive Research Lab led by Dr. Jamila Stockman. The first on the screen I am particularly proud of as my dissertation research study, and it's called IC, a study of the effect of structural inequities and syndemics on participation in HIV research among Black women, a population of whom are disproportionately affected by HIV and drastically underrepresented in HIV research across multiple disciplines. So that includes cure, treatment, and prevention. Next slide. So my dissertation study is a mixed methods focus, or is a mixed method study, and it has 3 aims. So using a case control design, I'd like to quantitatively examine how specific social structural inequities that include structural racism, HIV stigma, and medical mistrust, in addition to some structural factors that include past year substance use, past year IPV and adverse mental health, in particular past year depression and lifetime PTSD, and how these are associated or not with lifetime participation in HIV research among Black women. And so given that it's a case control study, 175 cases and 175 controls, the cases will have endorsed a history of previous research participation. For aim 2, I'd like to qualitatively explore, given that it's a quanta-qual, I'd like to qualitatively explore what some of the perceptions of social structural inequities that I mentioned above and how they impact lifetime research participation in Black women. So further expounding upon those themes identified in paper 1. And then lastly, I will conduct focus groups to identify strategies to improve said participation in HIV research among Black women. Next slide. And so here's my study flyer. Eligible participants include those individuals who identify as Black, who are 18 years and older, cis or transgender women, and are able to read, speak, and understand English. So I'm going to be circulating the study flyer through the Division of AIDS funded research networks, in addition to a cohort of participants who participated in a community training curriculum built and designed and implemented by women living with HIV throughout the Southeast United States. Thank you. Next slide. So the next study I'm going to be talking about is a study led by Dr. Jamila Stockman and Dr. Keith Horvath. We call it Link Positively. It's a trauma-informed culturally tailored web app to support HIV care engagement. Next slide. And the study has 2 aims. So with input from Black women living with HIV, peer navigators, providers, and CAB members at the San Diego CFAR Health Equity Community Advisory Board, the app was initially developed. And then from that initial development, there was a couple of elicitation rounds to test. There were a couple of rounds of elicitation and additionally some usability testing, beta testing by Black women or those individuals who would be key participants in the intervention to help finalize the intervention components. And then aim 2 of that study is to pilot test and assess the feasibility, acceptability of the effect and preliminary effect of Link Positively, plus peer navigation among Black women living with HIV among some of the HIV care outcomes that Black women are not woefully represented among. So that includes retention and care, ART adherence, and subsequently viral suppression. Next slide. And here are the study flyers. We are still recruiting. We have, I think, about 20 more slots. So if folks have networks of Black women living with HIV, please kindly refer them my way. The study is being implemented in California, and recently we expanded to another EHE jurisdiction in the state of Oklahoma. Right? Lack of resources there, so it was appropriate.
Can you tell us about that briefly, like how that came to be? Because that's definitely a marriage I would not have been aware of.
In work, right, in community work, we partner with a Black-led CBO who spoke very robustly about the lack of women-centered services in Oklahoma in a context of increasing HIV diagnoses amongst this population of people. And so we got a request to come to Oklahoma and to bring resources with us. So we submitted a supplement to ViV Healthcare that was since funded. Really exciting work.
Very cool.
And then the last study in my slide deck, Women Shine. Oh, excuse me.
Bless you.
Thank you, thank you, thank you. Sorry, I think the format got a little wonky. So Women Shine is also out of the iStride Research Lab. It's in partnership with Dr. Laramie Smith, among others on a team of brilliant folks. But the goal of Women Shine is to essentially provide skills to help women develop and manage challenge to improve engagement in HIV care through peer support across the HIV care continuum. This study in particular involves all racial ethnic groups of cisgender women specifically living with HIV throughout the state of California. Next slide. Here are the flyers. It is actively open and recruiting, so please share far and wide and have folks reach out to us if interested. Thank you.
Danielle, for that study, there is no race or ethnicity requirement. It is just cisgender women living with HIV in the state of California
That's correct.
who are above 18.
Yes, I'm sorry.
Okay.
On the
Okay.
on the left, it describes who can participate in Women Shine. So women, as you mentioned, 18 and older, cisgender, both who were born as and identify as a woman, living with HIV, living in California, and with an interest to participate.
So they don't have to be people who've been out of care necessarily or poorly adherent. Okay. Good to know.
Folks have to have been prescribed HIV meds.
Okay.
Yes.
Thanks, Danielle.
Of course. Thanks for the opportunity, Jill.
Okay, I think this is me now. So I'm going to talk about 6 studies, 3 as myself, a couple for Tom Martin and 1 for Laramie Smith. Obviously, we are, just the leads. We're not the study. But I wanted to talk about a couple of studies that we just recently launched at the AVRC and we are excited and looking for participants. So a lot of people had heard of Purpose 2, which was a study looking at one-to-one blinded randomization of gay and bisexual cisgender men and transgender individuals at risk for HIV who would either receive oral TDF-FTC or injectable lenacapavir. That was Purpose 2. It's fully enrolled. There should be some results from that study probably later this year. But Purpose 3 and Purpose 4 are now open and enrolling. And we are actually the only site in the United States that's open for either of these studies right now. So we're trying to gobble people up now and say, look at what we can do in San Diego. So need your help with that. So what Purpose 3 is, it's a one-to-one unblinded randomization. So people are randomized to either receive TDF-FTC or Truvada versus injectable 6-month lenacapavir. And just want to remind people that injectable lenacapavir is approved for treatment of HIV. And I know we're starting to use it at the Owen Clinic for treatment experienced folks, and in some cases for people who want to do injectables but may have viremia or some resistance mutations. So we're using it, and this is for HIV prevention. Who's eligible for this study? You have to be HIV negative, which obviously we will determine at the study, 18 years of age and older, and then very low bar. And when I say low bar, I mean there's not a huge amount of criteria that would make you eligible or not. You just have to be a cisgender woman who's been sexually active with a cisgender man in the last 12 months. The two things that we have noticed have made it so that people can enter study is that you could never have received any long-acting PrEP. So anyone who got Apretude, cabotegravir, unfortunately doesn't qualify for the study, and you can't have untreated hepatitis C for this study. That's come up for a couple of cis women who've been interested in this study. It's very well paid, $100 every study visit. We were actually just calculating what the amount would be, and if you got randomized to the Len arm, you could earn up to $1,450 in the course of a study. Obviously, it's not an approved medication for PrEP, so obviously that's one of the reasons we can do it. And I see Nettie has a question. I'm going to just show you the study schema because it goes for the next study I'm going to talk about as well. This is a one-to-one randomization. What's different than Purpose 2, where we had a lot of people who were already aware of, TAF-FTC or Descovy, and we would say, well, you're going to be randomized to lenacapavir or, maybe back to Truvada or that other medication. Here, if cis women are on it, it would be the same medication they're on versus switching to lenacapavir. So one-to-one randomization for the first 52 weeks. And then there's a PK tail washout period until week 78. So Nettie is asking how to justify offering unstudied injectable PrEP when we haven't approved. Well, that's what we're studying. Maybe I don't understand the question. That's how we.
Sorry. Well, so first of all, sorry, I know we're on like rapid rounds, so I don't want to interrupt, but
sure.
And I think you said this maybe was only women. I missed the last slide. So
this is cisgender women. Yep.
But what I was getting at was like before we had long-acting injectable, I could see studying another long-acting injectable. But once you have it, then it's like, are patients educated about? Yeah, once you have another long-acting injectable, then you're asking them to participate in an unstudied long-acting injectable. So I was wondering about the ethics of that.
Because it's every 6 months, which is a very different thing than come in every 2 months. I mean, I'm not sure how you felt about Purpose 2, which enrolled 3,000 people. It was the same concept for that. Apretude was already available, but we were having people come in for lenacapavir versus Truvada. And it just gives people, like everyone's saying, more options. I have a lot of patients who, if they can just do it twice a year, they'd be really happy about that. And I don't know about you, but Darcy's like reading my mind. For a lot of patients, coming in every 2 months is really a barrier to Apretude. And I would say for women, the fact that the only pill that they can take is still this big horse pill is not super fun. So this is another option and not studied in them. I hope that
Gotcha.
answers that.
Just educating, like they're offered
Yeah.
Apretude and then, yeah, okay.
They're not offered Apretude. They cannot go in the study and get Apretude somewhere else. It's not being offered in the study, though. The study
I just
is,
meant education wise, like.
oh, yeah. And there are patients, we just had someone who was referred to our clinic for Apretude. We are going to offer them the study. We're going to say there's this option, or you obviously can do Apretude in the context of, through the clinic. But yeah, just another option for people. It's subcutaneous. Some people don't love the idea of intramuscular. So if you thought that was controversial, no, I'm just kidding. Purpose 4 is a really interesting study. Obviously, same medication, but it's a 1-to-2 randomization. And it's for HIV negative people above the age of 18 who are actively injecting drugs and have shared paraphernalia, any kind of paraphernalia in the last 30 days. They have to have evidence of track marks somewhere on their body, and they have to test positive in their drug screen for something other than marijuana. It is a very exciting and complicated study. And maybe at some point, because this is Rapid Rounds, we'll talk about our experience, because our incredible study staff has already screened 7 individuals, and they've said, and I don't know if anyone's on, it's been the hardest study that they've ever had to be part of. Blood draws are really, really difficult. And really the way that we've been successful so far in bringing people in is partnering with Steph Strathy's Las Fronteras study, who are able to bring people into us. Because again, a patient population who's actively injecting drugs, in the middle of a study visit could be like, I feel like I need to go use right now. These are all things that are a little bit different for our study site, and it's been really an amazing effort to do. I should have said, I'm sorry, I thought this was listed here, maybe on the flyer. These are both HPTN studies, HPTN 102 and 103, and we're the external site that's participating in this. So we are not an HPTN site, but we are the only site that's enrolling right now. And it looks very similar. I just wanted, oh no, I didn't include it. The difference here, in addition to the things I said, you can have active hepatitis C, because they knew that excluding that would limit the population dramatically. So really, I think what's been most difficult is getting the blood draws. It's a good volume, and obviously someone has to have some veins that we can get from. And I think you can see for this study, Michelle Arsburn has been amazing, and as our study coordinator took over for George Latapez, who's not at the AVRC anymore. And I just want to thank Steve Hendricks for all of his help on this. It's been really incredible to be able to do. Okay, sorry, and I want to keep moving. So then the last study I'm going to talk about is the Get It Right study. It's an AIDS clinical trials group study. And the background is that there have been no research studies looking at the bidirectional effect of antiretrovirals and feminizing hormone therapy in transgender women. Thanks, Danielle. I do feel like these are all like finally studies. That's how I have felt, and that's why I'm so excited that I get to be a site PI for these studies. This is like, oh my gosh, finally. And I think you're saying finally because Danielle and Sarah Gianella and a bunch of others have been in the background fighting for this with the ACTG, I think, fighting along with the ACTG to get this study going. I think it's about 5 to 8 years in the making. So it's finally launched. And it is a little bit of a challenging study to enroll. So people who see trans women, I just want you to listen to some of the eligibility criteria, and we're always happy to talk it out with you. But so it's transgender women over the age of 18 who are taking ARVs, and they have to be on ARVs for 6 months to be in the study. They cannot be on estradiol at study entry. They could have been on it a month before, but basically they want to be either interested in starting it or restarting it. And I'll show you the study schema on the next slide. The other maybe bigger pill to swallow is no spironolactone use for the first 6 months of the study. $50 per visit. There's a PK that's voluntary that they can be in where they can earn up to $200. And what's really cool about this, and this is how I'm trying to tell patients that this is a little different than regular clinical care, is that there's oral dose escalation at each visit based on estradiol concentrations and participant desired goals. And I'll show you what that looks like on the next slide. Here is the study schema. So again, on ARVs for at least 6 months, viral load has to be undetectable, and there's certain criteria for that. But then the big thing is no oral hormone therapy for 14 days and no injectable for 30 days prior to study entry. And then people come in, and there are 3 groups of ARV regimens that someone can be on. The Biktarvy regimen, which is what a lot of people are on. And then there is a dolutegravir containing regimen that they can be on, or a darunavir containing regimen. The reason these are the 3 options, it's an international study, and this is what is most commonly available throughout. This was designed before rilpivirine cabotegravir, unfortunately, because it'd be wonderful to have a 4th study arm with people on long-acting injectable cabotegravir. I don't believe that will happen, although it's been discussed. I think the key, and then I'm going to show you the slide, and then future slide, I'll show you the estradiol regimen. Here are some important criteria. So in addition to wanting to start or restart, estradiol level has to be less than 75. That just really means you're not taking it. And then willingness to avoid the non-prescribed anti-androgen, which I believe is just spironolactone, and I'm not as worried about finasteride. And then something that has made it so that we could not enroll a few people that we've screened is history of DVT or some sort of clotting disorder. So this is how the dosing regimen and escalation looks, which is kind of interesting. Basically, you start at 2 milligrams oral estradiol and can go up every 2 milligrams at every study visit, depending on your estradiol level. So as long as it's under 100, you can keep dose escalating. You know, you say you want to keep going. And what I've been telling a few patients is it's rare that we have people on 8 or 10 milligrams of oral estrogen, because it's just not what's in the guidelines. So this is a study that's going beyond that, and actually maybe sort of a safer way to do it. So that may be a plug for some patients, but for people who are on injectables or patches, you know, and want to stay on that regimen, this obviously wouldn't be the right study for them. All right, now I'm Tom Martin. I was going to pretend I had a British accent, but I'm not going to do that. So this study is called Empower. It's a really easy study. Basically, it's long-acting injectable cabotegravir to Biktarvy. Basically, the data right now shows that about 20% of people on long-acting ARV therapy stop therapy, but there aren't studies that look at the efficacy of oral therapy after they discontinue. So they basically want to look at the safety of the switch, and then also the PK of the study drugs. It's only a 35-person study, so it's a very small study, and you need to have had at least 1 injection of cabotegravir in the Q2 month dosing, and it's 5 visits, total compensation up to $650. We've all talked about the fact that there's minimal benefit, although the idea is if for some reason you're stopping cabotegravir, why not get paid to go back to your medication that you were likely on before? The key, though, is notifying the study team well before the next injection is due. So really, Tom says about 4 weeks before. Obviously, you could even do it like on a day that a patient comes in and says, I think this is going to be my last injection, or I'm really thinking about stopping. That would be a great time to alert Tom to this. And he says, call or email or however you want to get a hold of him. The next study that hasn't enrolled quite yet is looking at oral Biktarvy versus oral Biclen, and it's to basically look at the efficacy of the fixed dose combination. And the main outcome is RNA greater than 50 after 48 weeks. So you can see it's a double-blinded study. It's actually going to be quite a large study. So almost 550 people. They get randomized. They will not know which arm they are in. And then there is an open label phase at the end. Similar payments. Let me go to the next slide. It's, again, earning up to $1,300. I don't know if this is a strange thing to say, but, we have a fair number of Gilead studies going on, and we have now negotiated because it is hard for people to come in and do things and give up their time. Study visits for these studies are $100 per person now, not coercive, but actually commensurate with their ability to come and participate. Again, get in touch with Tom if it's something that you're interested in. And Nettie, your question about who is eligible, the only issue with failure, I just want to double check, they could have failed it. Yes. That's more in the nitty-gritty of things. I don't think there's any reason they can't be in it if they failed. But they have to be virologically suppressed. So I'm assuming failure would probably mean not virologically suppressed, and thus they wouldn't be able to be in it. Does that help answer? They have to be suppressed on it. So
got it. Thanks. I missed
yeah,
the
so
suppression part. It's like
that wouldn't
going
work.
fast.
But I mean, we have people who want to go off it all the time for various reasons. It's usually like the schedule isn't to their, it's too much, or they're not liking the injection side effects. So yeah. All right, and now my last study to present is study I'm actually involved in, but this is Laramie Smith is the PI, or she's co-PI along with what is wrong with me, Malik. Or Malik Gabernek at the center, and Marisol Leo from the Transgender Health and Wellness Center. Sorry, my brain. And it's a study called the Trans Health Project, which was designed by and for transgender women. It's a very community engaged approach to research, where they're basically trying to determine an intervention that will help keep people both living with and at risk for HIV engaged in care. But it's really sort of designing an intervention. So 6 study appointments, 40 minutes each. You get to do some surveys in them, and most of them are in Zoom or can be over Zoom, decent compensation for it. But it's a really cool study, I think, similar to Encore, in that it's really trans-led in a lot of ways. And there are a lot of great people in the San Diego community who are involved in it. Okay, I think that's the end of me. Miley.
Hi.
Hi, Miley. Yes, we can hear you.
So I'm giving just a brief overview of the study that is coming. I was hoping that it would be IRB approved and ready to go by today, but I hear I'm 4th in line and probably will hear about approval next week. So I'm kind of just giving a snapshot of what we're doing. So this study is called Women-Focused Encounters for Resilience, Independence, Strength, and Eudaimonia, also known as the ReRise study, which was really influenced by the Maya Angelou poem, which I just absolutely love. Next slide. So in general, I think most of you who know me know that one of the reasons that I love research, and I just have not been able to give it up despite the work that it is because it's a way that I feel that I can provide opportunities for my patients that I can't get paid for by insurance. And one of those things is the pursuit of known strategies and treatments that we know work for folks, but are just difficult to access or not paid for by insurance. So the WeRise study is essentially evaluating the implementation of a bundle of interventions, which include acceptance and commitment therapy, exercise, and social support for women who are living with HIV. To be fair, I have submitted this grant a couple of times under different guises, but this time it was approved under the EHE realm. So we are really enrolling cis women who are either not virally suppressed or struggling with taking their medications every day. We know from the literature that women in particular tend to kind of go back and forth on their antiretroviral adherence just based on what's going on in their lives. And that's not always reflected in the viral load. We also know from the literature that having a higher level of adherence decreases your risk for ongoing comorbidities, such as cardiovascular disease and things of that sort. So in that context, you don't have to be virally suppressed for the study, but you do have to have some report of not taking your medications perfectly. We also want to be addressing the SAVA endemic, the substance use, violence, and HIV syndemic. So we will also be including women who have some level of substance use, and that can include alcohol and tobacco, because we also know that any type of substance, including alcohol and tobacco, increases the risk with aging for frailty and other negative outcomes. So we're taking all comers substance use. And they also don't need to be actively in an environment where they're experiencing violence, but we do want some history of either interpersonal violence or childhood trauma. So that's kind of our inclusion criteria. Because our focus for this is really to enhance and address social and structural disparities of health and create an intervention that will be sustainable once the grant is over. We are going to be delivering this in community-based organizations across the U.S. First here at Christie's Place, and then in the next year, we're going to go to Charlotte and be partnering with By Stripes Wellness Center. We will then come back to the West Coast in LA with APLA Health, and then lastly, we will finish our study off in Atlanta with Sister Love. Each of these CBOs are going to be identifying someone who already works in this organization to come here and be trained to mastery to do all of these interventions. So one of the other things that we're tracking on the side is, what are women doing with this learning base or these new skills? Are they able to seek new employment for themselves, either once the study is finished or while the study is ongoing? And how does that improve their opportunities and address some of the disparities of health that we know exist for women across the board? This is a fairly intensive intervention. So it is an 8-week intervention because, again, we really, it's 3 in 1. So we have to do a lot. And it's technically 2 weeks, but we are going to be giving a hybrid option, knowing that, it's really difficult to get to participate in something twice a week. Because it is an implementation science study, it's essentially a type 1 hybrid, looking at both effectiveness and efficacy. We kind of have 2 phases of study. So the first phase, for the first 6 months of each of these CBOs, we're going to ask them to deliver the intervention as we have taught them and as we have laid it out. And then after that period of time, we're going to meet with the organizations and along the first 6 months, we're also going to be tracking with periodic reflections, like how are things going, what's difficult. But in that 6-month period of time, we're going to sit down with everybody and say, hey, we know it's really tough once these grants are done and once the money goes away to continue these things. What do you need to do to alter this intervention? Or what are you hearing from your staff and the participants that you think would make this something that you could continue to do in perpetuity? So we're going to let the organizations decide what needs to happen so that they can keep delivering this intervention in a way that they think works for them and their clientele. So the second 6 months, we're not going to be, demanding anything. We're just going to be like, okay, do what you want to do. We're going to sit back and just observe. And we're just going to be tracking the adaptations that are made to the intervention, evaluating along the lines, like whether or not it is still efficacious and the like. So the other cool thing about this study is we really wanted this to be very community-centered. So we have contracted an independent study advisory board of women living with and affected by HIV, and they are truly going to be developing and guiding us along the way. So it's being led by Ribbon Consulting, and they kind of created their own way. They said, okay, we love this idea. This is what we want to do. So we didn't even tell them like, this is how we want our study advisory report to be. We're like, what do you want to do? And they're like, this is what we're going to do. So that's another really cool, exciting thing. We're going to be tracking how they develop this truly independent community study advisory board using the transcreation framework. And hopefully that could be a guide for future work as well. And again, if you're interested in getting more details, if you are interested in me sending you our recruitment information, once it's officially approved, please email me. That's my email at the bottom. Thank you.
Thanks, Miley. Sorry, I guess I cut off the study part. All right, our last study, Dr. Robert Dice, where are you?
I'm here. Thank you, Jill.
Great.
Thank
Why
you
don't I
all. And I
see
can be quick
you?
because I know
Hey,
I'm here.
where are
I don't
you?
think you wanted to see me running around. I can be quick because, you know, we did a talk about the last gift study not long ago. People are probably familiar with the study HIV Cure Research, enrolling people at the end of life. And so we got a supplement recently to recruit people without HIV. 5 individuals who could stir, you know, with the idea of they would be, you know, sort of study controls, and that helps us maximize, you know, the data that we've already obtained. So I do think, and the reason we point this out again to the High Rounds crowd is because this is a unique opportunity really for next of kin and partners of friends of some of our patients to participate in HIV-related research that they might not otherwise. This is a community, obviously, that cares about these issues. And so, you know, it's a good sort of group to reach out to, or if you certainly know somebody, you know, our information again is at the bottom. We're doing, you know, sort of other community awareness, but, you know, theoretically, at least the closer we get to sort of matched participants, you know, is also helpful. So again, just putting the word out that we're recruiting. We already have one participant, and we just performed the autopsy about a month ago for that person. So we're recruiting 4 additional people without HIV who have a hospice qualifying condition, same sort of criterion.
Robert, how did you enroll that person?
Yeah, see, you know, it was a friend of a friend sort of the CNTN study. I think someone that our coordinators knew, you know, who also knew somebody in the CNTN study, the parent study of Last Gift. So again, just kind of showing that, you know, the community around this are probably who cares and might be more interested in, you know, in participating.
Have you talked to the PAL care group about this?
Which, sorry?
Palliative care?
Of course, yeah.
Oh, okay, okay.
They have, you know, it's more difficult than we'd hoped or anticipated to sort of have them have these discussions with people. They have a full set of, you know, their own clinical and, you know, psychosocial priorities that they have to go over with, but they are aware. Yes.
Can you go again with the inclusion criteria, Robert?
Sure. It's generally people who have a terminal condition within, say, you know, 6 months expected or not. Sometimes we enroll with our, you know, with our HIV cohort, we kind of go a little further than that, you know, because we can follow people for years. But I think this is a shorter supplement that we'd really try to get people who are close to dying, maybe around the 3 to 6 month or even shorter period. Resident of San Diego County, and you know, that's really the only you know, sort of requirements. There'd be a blood draws and, you know, in the and study surveys in the sort of pre-mortem period, and then, of course, the rapid autopsy at the end.
And from any condition, any diagnosis.
Right. Yes. Yes. Yeah. Okay. Well, thank you.
Well, don't go yet. I
I'm
think
not.
everyone, you're good. Okay. My hope was that everyone who presented turned their camera back on. And people can ask us questions, or we can dialogue with each other as a research roundtable might look. So let's see, where are we all here? I'm going to stop sharing. That will help me dramatically. Okay, because now I can see everyone. Oh boy. Sorry, my computer's gonna die in a moment. I don't know if anyone has any. So I can't see me struggling with this computer situation. I don't know if anyone has any particular questions. Jeez.
I had a question for Miley. It's just because I missed a tiny portion of what she was saying at some point. But Miley, you were saying, so the intervention lasts 8 weeks, but you mentioned that after 6 months, they are left to do whatever they want. So is it that it's going to be 6 months of different participants coming and having their 8 weeks, and then they're going to adapt the intervention based on what they saw during those 6 months and what people enjoyed and what worked for the staff? Or I was interested in that bit, but I kind of missed it.
Yeah, no, sorry. So each site has a year with us, and the first 6 months it's going to be as it is, like a traditional clinical trial, or I guess behavioral social trial. And then the second half is and we're going to track very closely. In the second half, we're not going to be telling them what to do. We're just going to kind of like observe. Still, of course, because it's a study where if there's adverse events, we'll be tracking those sorts of things. We're not going to stop doing the research procedures that are required for running a study. But we really thought that there was a lot of rich information that we could get from these different organizations, which are all very different in size. They're all very different resource. Most of us know Christie's Place is a smaller-ish, organization, but they've been around for a long time and they've done a lot of good work. The opposite of that is probably APLA up in LA, which is highly resourced, huge, tons of money. And then there's like By His Choice Wellness Center, which is run by 2 people, and they do their work out of churches, So I think for us, we felt it was a really rich opportunity for the research team to just sit back and be like, okay, if we can get a lot of information about strategies that work and enable this intervention to be sustainable after the research team is away, that would be super helpful to eventually result in multiplication of this intervention across the US and even internationally, because ultimately, we want people to just have access to things we know will help them. And there are a couple of lifestyle interventions like this, and I've modeled it after them. So the diabetes prevention plan is very similar, and the Ornish cardiovascular disease plan is also very similar. They all incorporate aspects of social connection or education, activity, exercise, and then depending on for those 2, there's also a diet thing about it, because diabetes and heart failure have specific types of diets with them. And so those plans are technically billable by insurance, but most insurance doesn't cover it. So there has to be a way to supplement it in some way. So even though these are highly proven to work, the diabetes prevention plan actually outbeats metformin in terms of preventing diabetes. Nobody can access it because hospitals and healthcare systems struggle in being able to put these together and keep it that way. So we're trying to go a different route where we want to do something. Thankfully, HIV advocacy has been so deep rooted and active in the US, at least, and internationally, that we have a lot of community-based organizations that are strongly committed to providing care and services for people living with HIV. So we thought, just kind of shifting away from the healthcare system, since these have been strategies that have not worked despite all of the evidence around it, let's try to see what we can do in the community.
That's great. And how are you doing the observation? Is there actually going to be somebody from your team checking out what they're doing, or are they filling forms of what they've changed? Or
Yeah, no, we're going to be evaluating. So we're basically videotaping and watching and listening to the intervention over time. And we have fidelity checklists for all of the different things that we're looking at. We're going to be tracking adaptations using Frame IS, that the implementation science framework. And also doing periodic reflections every month with the team.
Sounds amazing. Thank you.
Sure.
My question to the group, and this is to all the researchers on, maybe with the exception of the last gift, because it's sort of a little bit of a different study, but I don't mean to exclude Robert. It does feel like a lot of the time there's overlap in our studies because we're working with different groups. How do we think we do better from that standpoint, making sure that we're all aware of the studies that we're doing and that if there is overlap, that there are ways to collaborate? What do y'all think about that?
I'm gonna start. I mean, I think it just reminds me of one of the seminars for the division, like maybe a month ago. We were talking to people from the community. It was basically talking to people with lived and living experience. And I asked a similar question. It was more in terms of like fatigue to participating in studies among transgender women, because I mean, they're like, being called from every corner. And I asked, what could we do to reduce that burden? And one of the people who was talking in the panel said, well, maybe you should just talk among each other and do one study that answers all of your questions. And I thought we should be doing a bit more of an effort because I mean, there's like, I don't know, like 5 studies among transgender women in San Diego only right now, right? But I guess that's a bit different to what you're saying, because you're saying, well, it's fine to have different studies, but how are we aware of what each of us is doing, right? But perhaps
I mean, it's also right where the funding comes from, and if you can get the funding, it's great. Yes, I was absolutely thinking of some of what's happening. I mean, it's wonderful that there's so many studies that are trying to enroll transgender women, but it is a lot, and there's a lot of overlap. And probably, Danielle, although maybe less in San Diego, but a lot of studies that are trying to enroll Black women living with HIV, and there's like a little nuance to each one. I don't have the answer. I was just curious what people thought about, how we can do this, other than I think and by the way, we'll try to do these research roundtables more frequently. There was a great response from people, and I'm sorry if you didn't feel included. Please let us know if there's a study that you'd like to talk about, sort of like this. We tried to do this a few years ago, and it was like pulling teeth to get people to do it. But we'd love to do this at least twice yearly, if not quarterly. But we need to, if we don't know at the AVRC what's going on, we won't necessarily know. So we weren't trying to exclude anyone. Nettie, you have your hand up.
I was just picking up on Anik's comment and thinking, why can't you just study everything? Like that's so how the patients see it, right? When they're like, why isn't this all just in my chart? Why can't you just all study one thing at once? But I was thinking about the impact on our patient community, right? We don't have a huge patient community. And so sometimes they feel pulled in a lot of different directions or commoditized or, that kind of thing. And so it would be, I don't know how to do this, but helpful to sort of categorize our studies by topics in a way that's like, this is really looking at African-American women, or this is looking for, and sort of help group them that way. But I do think that we need to even internally communicate better so that we are not all nibbling at the same hand of one patient or another. And so, yeah, I'd be very interested in participating in conversations around that. I don't have any really great ideas at the moment, but just maybe thinking about even internally sharing, like, here's a list of things that are looking at Latino MSM, right? So that when you're doing something with, you're not all kind of competing with each other, or you could maybe even collaborate on the next follow-up study together because you both found something that relates to Latino MSM.
Do you think, oh, sorry, Anik.
Go ahead.
No, I mean,
Unique,
my
but then
comment was-
Miley, yeah, no, go ahead. It's meant to be a round table.
Yeah, no, my comment was basically going to be what Nettie just said about having a database where we know what others are doing. And, you know, as we were talking about yesterday, for me, it's useful to know about other studies with transgender women in San Diego, especially because ours excludes women who are HIV positive, which is an issue. So it's very useful to be able to give them an opportunity to participate in another study if they can participate in ENCORE. So there are some complementarities that could be leveraged. So I am happy to help building that database if we want to do that.
I was just going to say, do you think it maybe could live someplace like the HIV Institute or like the hopefully new future CFAR website?
I guess
I
the
would-
only issue would be with that, and I'll turn it over to Danielle and Jamila. Go ahead, Jamila. Sorry.
Oh, I
Go ahead.
I just wanted to say, I believe the CFAR does have a database like that,
That's correct.
where they collect information on ongoing HIV research studies that are looking to recruit participants. I don't know how utilized that database is, and definitely based on this conversation, it's definitely something to follow up on. I'm happy to do that, and it may mean that we need to rework the database a little bit to accommodate some of the needs that are raised here.
Or even promote it. I've had participants reach out about several studies that they found out through that database that Dr. Stockman is referring to.
Nettie, I don't know if you have another comment or your hand still remains up. It's okay.
No, I didn't push the hand down button, sorry.
No problem. I mean, I will say, I don't know if Marvin wants to come on or if I don't mean to call him out. It's in a good way that you know, we used to sort of have this nice flyer that at least for studies that were going through the AVRC, and that is clearly not the case because not everything's going through the AVRC, but studies that were for people who were living with HIV, people who weren't living with HIV. But now it feels like there's so much more nuance to it. And the question is it worth trying to bring something like that back out that, you know, really categorizes thing and is sort of a nice resource for the community and for providers, not just at UCSD, obviously.
Yeah, I mean,
Yeah.
I used to do something where it was like for treatment. I kind of grouped it in that sense. You know, Miley helped me with that, was like for treatment for people that were looking for prevention, people kind of grouping that way. I did that for a little while. I wasn't really sure how effective that was or people really utilized it. So I kind of stopped doing that. But that's something I can always bring back. You know, also trying to make it small and easy to put in your pocket, things like that. You know, so it was basically like a 1-sentence description about the study, but categorized by groupings that we did based on treatment, prevention, etc. So.
Yeah, I think it came up. I mean, I remember thinking it was great. The problem is obviously you have to keep up with it, like when a study ends, when something new comes in. I think it came up a lot last night on our transgender community advisory board. Oh, it's 9:01. I'm so sorry. But there were, I think, 4 studies presented that were all a little similar, but they were different. And everyone was like, how do I keep track of this? And I think having that may be very worthwhile. So maybe some great minds can get together. Maybe Jamila and Marvin and Anik can think about best ways to do this, or others. But anyway, thanks everyone so much for joining us. I hope this was nice and informational. Obviously, email any of us if you have questions about the studies we talked about. And we were definitely going to do this again. I think Marvin and I said we'll hold a date for September. For the next research roundtable. And again, I think the idea is more for studies that you are in the process of recruiting, not like we will be. But Robert had an idea of having a slide that says, like, you know, future studies, here's what's coming, so people can have things on the horizon. But I think the idea is we want people to be able to actively recruit through these roundtables. So anyway, thank you so much. And Nettie, thanks for that. Yes, good. I think that was very nice. Okay. Thanks, everyone. Have a great weekend. And we'll see you soon. Croy series starts in April. Different people will be doing report backs from Croy. So hopefully that'll be nice and interesting for all of us.